My name is Jim Stone, and I'm the chairman of the board of Management Sciences for Health. Management Sciences for Health has been one of Boston's best kept secrets, even though that is certainly not our intention. The reason it's been so little known is that we worked for 43 years quietly behind the scenes, strengthening health systems in dozens of the most underserved countries in the world. We're a large nonprofit with over 2,500 staff members currently on the ground in over 40 countries. And in fact, we're Massachusetts' largest nonprofit international health organization and among the nation's most active humanitarian global health service providers. Because we believe that our greatest contribution to lasting health improvements in underserved countries depends on locally led, locally run health systems, we don't provide highly visible, hands-on bedside care. Our folks are experts in the facilities, programs, and logistics of healthcare, including emergencies like this one, and in preparedness tools to prevent and contain health emergencies. I don't need to spend time trying to convince you this morning that Ebola is an international crisis. We hugely admire the medical professionals who are risking their own health to provide the hands-on care, but we and they will all share the greatest relief when less of that kind of care is needed. This is a crisis that requires hands-on care only when prevention has failed, and where hands-on care can only be provided safely with highly protective facilities and logistics. That's a situation that calls for MSH's attention and utmost effort. With that introduction, let me pass the microphone to Dr. Jonathan Quick on my right. He is MSH's president and CEO. He spent a lifetime in this field, including as a top executive at the World Health Organization. He will tell you about our immediate plans to help on the ground with health facilities, detection, and preparedness in Liberia, and our plans to enhance preparedness in Côte d'Ivoire, the Democratic Republic of Congo, Nigeria, Gabon, and Ghana. This is no small undertaking, of course, but I suspect it's only the beginning of MSH's involvement in fighting the spread of Ebola. John, the microphone is yours.
Thank you. Good morning. I'm Dr. Jonathan Quick, President and Chief Executive Officer of Management Sciences for Health. Let me begin by setting the scene in Liberia. After 30 years of civil war and disruption of every part of society, nearly a decade ago, a Harvard-trained, now Nobel Prize-winning Ellen Sirleaf Johnson was elected president. And over the years since then, there's been a huge effort to build and rebuild the health system in Liberia. But since March 2014, the unrelenting and expanding Ebola epidemic is taking apart and destroying much of what was created, at least functionally. Nearly 4,000 people have been infected in Liberia, with about a 60% death rate. In the overall region there, of the 3 countries most affected, estimates are as high as 1.5 million people being infected. That translates at the death rates to hundreds of thousands of deaths. In Liberia, this health system is overwhelmed. It's overwhelmed by people coming in with Ebola, and it's overwhelmed because the health workers in many facilities are just scared to go to work. So the result is that regular care is suffering, and the system is just overwhelmed. Immunization in some parts of Liberia has fallen from 80% to 20%, according to reports that we're getting. Women are afraid to go to facilities to deliver, and home births are not safe in that part of the world. And so home deliveries, yeah, they're not safe in that part of the world. And so the basic care is suffering greatly. In times of war, more people suffer and die because of disruption in health services than because of war injuries. we're expecting the same thing with the Ebola epidemic. The disruption of regular health services may well kill more people than the Ebola epidemic. The treatment units, the Ebola treatment units, are overflowing. And with Ebola comes intense fear and panic. We have the story of the 8 aid workers and journalists who suffered mob violence in Guinea out of fear. So it really is quite a dramatic and horrific situation for the people of Liberia and in that region. But there's some pockets of hope. And I'd like to share one of those that relates to what I would call 750 Liberian quiet heroes. In Liberia, as in most parts of the developing world, there are really at least 2 health systems. There's the formal government system of clinics and hospitals, which may serve a quarter of the population, 30%, 15%. It doesn't serve the majority. The majority of the population typically is treated through the informal sector. It's often the drug seller down the road. Most countries ignore that. Liberia didn't. 3 years ago, in partnership with the Gates Foundation and Management Sciences for Health, they set out a program to train and license these community drug sellers, these community medicine sellers. Today, there's 750 who've been trained. All of those are in Montserrado, the county in which Monrovia is, and that has 40% of the population. Those quickly, early on in the process, while many other people are still talking, our lead there, the Management Sciences for Health lead, Arthur Lurian, and the Ministry of Health and the pharmaceutical societies got together. They got some pharmacy students, some volunteers who went out and went to these shops, provided education in Ebola prevention and detection. And now, when a lot of the formal services are not working, these shops are continuing to provide medicines and health products for common life-threatening childhood illnesses and other health problems. And they're trusted local community providers of information on Ebola. So today, MSH is committing to mobilize our expertise and resources to support the people of Liberia in the fight against Ebola, which has brought the health system to a close, not to an entire close, but to a shutdown in many places. And it's building on this realization that of the combination of international know-how and local commitment and willingness to act in partnership. And that's the example from these drug sellers. We've got 3 objectives. Working to establish community care centers, restoring essential health services for non-Ebola patients and all of the other services, and finally improving case detection and contact tracing. The treatment units will save thousands of lives, but community-based prevention and response will save tens of thousands of lives. And Dr. Hartman will talk more about that. Just a couple of words on MSH's contribution and why we feel like compelled to move in this epidemic. For 40 years, we've worked to build health systems in some tough places, and very often in post-conflict places, in crisis places, like Afghanistan, like South Sudan, like DR Congo, like South Africa after apartheid, building a more equitable health system. So there's experience on the health system side and the kind of setting that Liberia has, but also experience with epidemics. Dr. Hartman, who I'll introduce in a minute, worked with our program on bird flu, avian influenza, in virtually every region of the world in over 24 countries, which was very successful in partnership with USAID and others in containing that epidemic. So there's some experience there. Another outbreak is inevitable, but the scale and impact can be dramatically reduced with steady investment in strengthening health systems in countries like Liberia. Liberia needs all of us, but as cases pop up around the world, I think the world needs all of us to come together to contain this epidemic. We can't let West Africa become an incubator, spreading Ebola continuously through the world. So let me hand over to Dr. Fred Hartman, who has been in global health for over 35 years, has worked in a variety of different settings and speaks from some deep experience. The team that we have dispatched a team to Liberia on Monday of 4 staff, which are listed in the press release. And Dr. Hartman, we got to get him out of here and off to the plane, because he'll be joining them. He'll be getting on the plane today and joining them tomorrow in Monrovia. Fred?
Thank you, John. Yeah, my bags are right over there, actually.
Please move the microphone.
Okay. Thank you. Yeah, my bags are right over there. So I think my plane leaves at 2. Yes. So we got to hustle. You know, you sort of let the cat out of the bag. Some years ago, more than I would admit publicly, but you did, I was plucked out of my residency and sent to the Vietnam War as a Navy doctor. And my primary job, of course, was to support the Marines, combat casualties. But when you're there, you can't help but become involved in the overwhelming catastrophe that war brings to a society. And that's what we're facing today in the Ebola. For me, it was a life-changing event. I came back and committed myself to training up in infectious diseases so that I could be very useful in that part of the world. As part of my training, I was asked by CDC, because I had a U.S. Public Health Service fellowship, to join the smallpox eradication program, and spent some time with them. And you know what? It worked. You know, my very first public health job, we eradicated a disease from the world, and I thought, how cool is this? You know, we can really do this. Well, we haven't come close since then. We keep trying to replicate this, but so many people think Ebola is like an invasion from outer space. To me, it's a bad cousin that's always been around, and it just pops up and you have to deal with it. We're very used to working with unexpected outbreaks or transmission of diseases from strange sources. I mean, how many of us ever heard of a masked civet before, until it was noticed that became a reservoir of SARS? And SARS suddenly exploded and shut down cities from Hong Kong to Singapore to Toronto. And so we worked a lot to stop that. And then avian influenza popped up. You know, who would have thought chickens could infect humans and cause high mortality? But they did. And as John pointed out, we worked a lot in that. We developed a number of technical approaches and tools. And you don't hear anything about avian influenza, do you? I mean, if you were working in Indonesia or Cambodia, yes, because it's still there. But you don't hear about it as a worldwide pandemic. We were very successful in controlling that. And that's why I'm very confident that we can address the situation and together with others on the ground control it. As John pointed out, we have sort of 3 fundamental pillars. The first is we have to respond to the Ebola epidemic itself and to the patients who are infected and families that are affected. If we don't, it just continues to smolder as it has. So we have to help strengthen the system for identifying and treating every case of Ebola. That has to begin at the community. We're going to use our trained medicine vendors to get community care kits out. They'll be dispensed free of charge. We will help procure them. And the kits are very simple, but they contain protective equipment like plastic aprons and boots and gloves and goggles and a mask for people in the community who want to take care of loved ones, a bucket, chlorine powder for disinfection, but most importantly, education and instruction about how to use these. We want to work with the communities using some of the approaches we learned in avian influenza. We had developed a manual called Leadership During a Pandemic, what your municipality can do. We've sort of simplified that and changed it to Ebola. We now have something called a framework for Ebola response and recovery at the local level. So we'll be working with the district health teams and the communities for them to set up alternative care centers out of the health system. This could be something like a closed school, a community center. It could be tents donated by UNICEF. The U.S. government is constructing some of these, but the idea is to have a place for Ebola care that's organized and maintained by the community, but is separate from the health system. Home-based care is a real option because many Ebola patients don't want to go to Ebola treatment units. They see them as death traps. They want to stay at home with their families. But we need to work with those families so they don't get it. You know, Ebola is spread by the desire we all have to care. And we have to make sure they have the tools to do that and the knowledge, and that's where we come in. Then the second phase is once Ebola is out of the health system, get the health workers back. They're frightened. They've seen many of their colleagues die. You know, 20% of the deaths have been in health workers. So we have to work with the communities. The Ministry of Health at the central level isn't going to get health workers, 500 kilometers away back in their health centers. The community will. The leaders will go out and say, please, you're part of us. We need you. Go back. Make sure our women get attended births and get prenatal care, and that children with fever get treated. And then we train them in what we call no-touch techniques. We train them in infection prevention so they protect themselves and that they don't get exposed to body fluids, because in the initial stages, Ebola could be malaria. It could be influenza. It could be, a gastrointestinal disease. So we have to treat them how to deal with these patients without infecting themselves. So that's the second stage. As Jono said, and I saw this firsthand in Vietnam, many more people will die of non-Ebola causes than Ebola itself, but it's the disruption of the whole system. And then the third issue, and why we're partnering with our colleagues here from the Harvard Humanitarian Initiative, is increasing surveillance. Families are so afraid, they're hiding Ebola patients. They think they're going to be quarantined and isolated, and frankly there is a stigma now and discrimination in the communities towards Ebola-affected families. It's not their fault they got Ebola, but they're being shunned to a certain extent. Well, we need to develop a structure where they have confidence in the government that it's okay to report all cases of fever. We're going to put some mobile phone applications into the hands of these medicine vendors so that when people come in for help, they can be tested for fever, they can be asked some questions, and if it's a suspect case of Ebola, they punch a button, off it goes to a more central location and feeds a response team that goes out. And then once the response team gets there, we could do the contact tracing. That's the only way we're going to snuff out this epidemic, is by identifying every case and do contact tracing. That's how we eradicated smallpox, and that's how we'll control this Ebola outbreak. So I think those three fundamental approaches are things we bring to the country, and that's why we're going out there. Thank you.
Let me grab this over. Thank you, Fred, and thank you all for joining us today. My name is Michael Van Rooyen. I'm the director of the Harvard Humanitarian Initiative and an emergency physician at Brigham and Women's Hospital. The Harvard Humanitarian Initiative works to help organizations like MSH and many other organizations to develop better processes and data collection systems to advance their work in the field. The recent reports and perpetual reports of the transnational spread of Ebola make it very clear Ebola is not just the problem of West Africa, it's the problem of the United States and the rest of the global community. There's no other option but to aggressively go after this disease, to identify it, to control it, and to eliminate that threat. Now, the images we see on the news most commonly are those of Ebola treatment centers and people dressed in personal protective gear managing infected patients. But the real fight in this is actually not going to be won in hospital. This war will be won outside of hospitals and in communities, in clinics, in dispensaries, and in sort of local communities and small villages. And that's where, I think MSH has this tremendous opportunity to really mobilize their network to change the way that we're looking at this. MSH has this wonderful and deep community-based experience in sort of local drug dispensaries and local community providers to leverage that to really gather information, screen patients, and refer them to the correct facilities. So HHI is thrilled to support MSH's strategy, and we're also thrilled to provide tools to help them be able to do it. As Fred mentioned, we have a product called the Kovo Toolkit. It's a sort of smartphone-based application. So it allows frontline health workers and communities to gather information, upload it to the cloud, where it is aggregated with everybody else's information. It's analyzed, mapped, GPS coordinated, and made available to the organization for management and understanding of where disease outbreaks are happening, where cases are being managed, and the types of resources that are needed to manage those cases. COBO has been used in multiple conflict areas around the world in some of the most difficult places, currently in Syria and Afghanistan and elsewhere, with organizations like the International Rescue Committee and Doctors Without Borders, as well as numerous UN agencies. It's a well-tested tool that we're thrilled to and very happy to deploy to work with our colleagues at MSH. It's how we'll win this battle, right? It's good information management, it's understanding and being able to count the problem and quantify it, and then to take an approach that MSH is such a strong part of, and that is a community-based approach from the roots of the problem all the way to treatment. The ability to manage that process better and coordinate it with others on the ground will be the key to eliminating this threat. So we're very happy to be hopefully part of the solution. Thank you very much.
Thank you.
Dr. Quinn, could I ask a question of Mike while Mike is still there?
Sure.
What you just, I'm sorry, I hope I'm not interrupting or out of line here. What you just talked about with the cell phones and the way to communicate and transmit information, which helps you guys gather information, that doesn't exist right now in Monrovia or in Liberia?
Actually, the cellular coverage and the digital coverage in Liberia in general is excellent. And so it has the infrastructure to be able to support that. There are multiple data collection tools that people and other organizations have developed over the course of many years. The utility of this one in particular is, first of all, it's extremely easy to enter data, so anybody can do it in the field. It uploads it to the cloud and then maps it and makes it available for anyone, anytime, real time to use. The key to good information management actually is that the data that we collect is not lost somewhere, but is actually useful now and available and sort of processed and managed in a way that sort of lay people can use. So the Ministry of Health or the Minister of Education or anybody else can look at these data and make sense of them.
So again, excuse me if I'm out of line, but so there is not that good structure for you guys right now over there to collect the data? Or is this app and this what you guys are going to set up is maybe better than what they're doing right now?
Yeah, I would say that it's better than what's currently available. So there are data collection mechanisms that happen, but they are typically not well integrated with other data sources, and they don't have the capacity to sort of instantly get data and map it and have it represented.
Thank you.
And that data, I'm sorry, and that data helps you send resources? I mean, why do we want the data?
All of it. So you think of the behaviors that people display when they're seeking healthcare, access to healthcare services, or that healthcare providers need information to manage patients as well, or they're going to move people to another site, or you're trying to order more personal protective gear, all of it. It's all about actually managing information. And you know, one big issue in this is that MSH's adoption of COBO and other organizations that adopt COBO as well, they can then merge their data and see each other's data, which has actually not been accomplished in these relief efforts before.
I might also say the Emergency Operations Center for managing the Ebola outbreak in Liberia is in the telecommunications building. It's an interaction between the private sector and the government. And the owner of that, who's one of the wealthiest people in Liberia, has said he supports this effort 100%. He will make sure that there's connectivity every area that we would put these phones in. So I think we're wired very well in that country to make this work.
Doctor, you talk about...
Quick question on you going right into that war zone yourself. How will you protect yourself? How will you protect your team from getting Ebola?
Well, a couple of things. Ebola is not as contagious as everybody thinks it is. I mean, you have to be in direct contact with a sick patient and their secretions. One Ebola patient will infect 2 others. There's a formula, you know. But TB, we deal with that all the time. One case of TB affects 7 others, and one case of measles affects 20. So, you know, on the scale of things, this isn't that contagious. I don't have any fear that we'll get Ebola walking on the street, you know. We really have to be in contact with secretions. The second is, I mean, I've been doing this my whole professional life, you know, And so you go in with your eyes wide open, you know where the risks are, and you try and identify them. We're specifically avoiding being treaters. I am a physician, but I'm not there to treat Ebola patients. That's not my skill set right now. I could do it, but I'm going to train others who will be willing to do that. In fact, we've been asked already if we would take over the infection control training for the whole country. We can do that. We have the training modules and the skills. That's how we protect ourselves. And the third approach is the no touch. Like I just shook Jono's hand. You know, that's what we're doing these days. And I was reading an article from one of you guys who was out there covering it, and he said he found himself backing up a lot. He was interviewing people, and he wanted to keep a 1 meter, 3 foot space. And as people approached him, he just kept walking backwards so they wouldn't get close to him. I mean, there's just a lot of things. I'm fairly confident, and even my family is. My family has said, you know, we trust you. We know that you've been in this situation and come out the other side. So you have to have, I think, concern, appropriate concern, so you don't take undue risk, but I'm confident that we're not going to walk out. In fact, that poor photographer who got infected, you know, admits that he was cleaning cars out and got splattered, and, you know, I mean, that's like the type of thing we're not going to do. You just have to avoid those behaviors.
Dr. Herman, you talk about infrastructure and more people die in times of war for not getting, you know, from a broken down healthcare system. Is it a mentality of if you build it, they will come, or how are you going to staff, you know, how will these be staffed? How do we know that just having the building or the tent or the whatever will draw people in and also allow for healthcare providers to show as well? Well,
that's really a series of excellent questions, and something that we've thought a lot about. I mean, whether it's pandemic influenza, which you know what happened in Mexico City and elsewhere. By the way, we were there, and we helped all of Central America to deal with that set of issues. Or whether it's Ebola. Once a single problem takes over the health system, people stay away. They just don't want to go and get it. And so women are dying at home of obstructed labor and hemorrhaging. We know that. And so how do you get confidence back in the health system? Well, they've lost confidence in the government, you know. So it's not central government, it's the community leaders that are going to do it. They're the people who are going to lead the way. I mean, I said that earlier. The ministry can order people back to work, but, you know, that order is meaningless 500 kilometers from Monrovia. But the community leaders say, come on, we know you. You're one of us. You're part of my family, you know. We need you. Please come back, you know. And we'll guarantee that Ebola care will be elsewhere. You won't have to deal with that. So it's the local leaders that can provide that confidence based on personal relationship. That's why we didn't know each other until last week. But as we talk, we agree completely on the way to approach this really is from the bottom up.
Is there the healthcare staffing, though, to care for this number of patients?
Yeah, there probably is. I mean, there will always be some people who won't come back. I mean, even the Ebola treatment units have been faced with strikes because people haven't been paid and they want additional sort of risk pay compensation, all of which is reasonable. But I think we can get them back. The other thing that we're going to talk a lot about is triage, which is an emergency medicine concept, but it's that you use your people most effectively. For example, there are programs like iron administration, mass medication administration for intestinal parasites, things that you might be able to suspend and take those people and put them into helping triage and control what happens. So for the time being, they'll stop that program, which isn't essential necessarily to saving lives. In the long term, it helps with growth and development. And we start repurposing people and retraining them. So we think that we can get the health system back up. It's a daunting challenge. It's not going to happen overnight. We were quoted in the Boston Globe that we said we were going to do it in 90 days. No, we're not. I mean, clearly we can.
So what's a typical internationally? But Dr. Van Rooyen, we've got you, Brigham Doc here. What are your concerns? You know, we hear about these 5 airports. We hear about, you know, a huge Liberian population in Rhode Island. What are your kind of thoughts, predictions on kind of a larger, wider spread Ebola outbreak in the United States?
So I think that we have, you know, excellent capability to manage any threat or any potential epidemic. I think that we're going to see more cases because there's always going to be transnational travel and people are arriving, and we'll see another case or another few cases. But we have tremendous capacity to manage public health threats like this. We have excellent public health messaging. The CDC has messaged this appropriately as well. I think if there's anything, hospitals need to have a more consistent plan with sort of understanding how to triage. But they've done, I think, a good job of messaging this, and certainly from our perspective at Brigham and Women's Hospital, the hospital seems ready. And then, of course, if there's a case, then we'll have sort of an escalated level of readiness. But I actually don't think that we face a threat of an epidemic in the United States.
So if I come back from Liberia with a fever, I go to Brigham and Women's, I give you a call and say, Mike, meet me in the ER.
I'll drive you there myself.
Is there a plan for that, doctor?
Don't go to Texas Presbyterian.
Yeah, we all have a plan for
If
that.
someone from the team were to get
Yes.
Ebola, would they come back to Boston?
Yes, we have a plan for that.
What is it? Plan?
Well, we're monitoring our temperatures every day, twice a day. In fact, I made this statement this morning at our staff meeting. I've realized I'm one really cool dude because my temperature never gets above 97. I'm fluctuating between 96 and 97. So the idea is if any of us ever develops a fever, immediately we go into quarantine and you catch it right away. You're not contagious until you have a fever, okay? And if it happens in Monrovia, we have evacuation plans in place, you know. There also, the U.S. government is setting up a 25-bed treatment center in Liberia just for healthcare workers. So they give confidence to healthcare workers that they can get early treatment. The little known, the mortality rate in Sierra Leone due to Ebola is 24%. The mortality rate in Liberia is 60%. The difference is treatment. 50% of Ebola treatments, Ebola patients are in treatment in Sierra Leone, only 20% in Liberia. That's why we're rushing all of this in. So early treatment does save lives. And so we're prepared for that. If I have to stay in a hospital in Liberia and that's my best shot, I'll do it. But I think most of us feel that one, we're not going to come in contact and get it, but two, if we do, we'll be back in the U.S. So I guess Brigham and Women has become my hospital of choice.
Do the trauma centers in Boston have the same capabilities as Nebraska and Lansing? Why them not us?
You know, I don't know why Nebraska specifically anyway, and I know that our Harvard-related hospitals, so Mass General, Brigham, BI, and others, have a relatively unified plan to manage a potential Ebola patient. So they're all, and those are drilled and kind of well articulated so far. So I don't know why the others, but I think we're ready.
Dr. Quick, you mentioned some numbers early on that you said 4,000 people in Liberia have Ebola.
Have been infected,
Have
yes.
been infected, and you got a number that threw me off for a minute. There was like did you say 1.6 have been exposed? Is the estimate?
No, okay, so there were three numbers in there. In Liberia, it's nearly 4,000 who've been infected, and the death rate's close to 60%. The top estimates of people who have been doing the epidemic projections, the top estimates are 1.4 million that could be infected by the time this reaches its peak and has come back down again.
And that was in several countries.
Yeah, that was in the three countries that are the center of this.
Why does it reach its peak? Is it something like, you know, are there seasons, so to speak, for Ebola or no?
No. It's. I mean,
When you get it contagious.
yeah, and the thing is, it depends greatly. One of the biggest lessons from the pandemic epidemic in 1918 was you compared two different cities in the U.S. You know, St. Paul and Philadelphia. The way they responded, because there was no vaccine and no medicines, the way they responded in terms of social isolation and all, their epidemic curves varied greatly just by the way they managed it. So that's why the whole idea of having community-based prevention and then detection. So just to come back to the accredited medicine shops, when we talked about the technology, Most epidemics, like SARS, was not the epidemic that came out several years ago from China. That wasn't detected by formal reporting. That was detected by a web crawler that picked up the outbreak of news reports. And what we want to do is, in essence, crowdsource epidemic monitoring with the technology that the Harvard Humanitarian Institute initiative brings, so that you're picking up that right early on.
Are you scared about going?
Me?
Yeah. Are you scared? I'd be scared.
No.
You
This has
didn't?
been my life. I'm prepared for it. Am I concerned? Yes, of course. Concerned enough to take precautions. But no, I'm not scared. I mean, we're going voluntarily. John hasn't twisted my arm at all.
I know,
It's,
but you didn't give your wife a kiss goodbye and say, I love you, I'm doing this. I mean, look, we go into dangerous situations all the time.
Sure I did.
And you're going into a
Of course.
dangerous situation.
Yeah, I did.
So tell me what a typical day is going to look like for you. Are you going to be in villages? Are you going to be in the neighborhoods of Monrovia? Who are you going
That's a
to be in
good
contact
question.
with?
A lot of our time is spent in meetings, coordinating and getting down clearly who's going to do what, so that we make the maximum use of the resources. I'm arriving tomorrow, and specifically our field visits have been timed to start Monday, so we'll be traveling every day out to some of the counties. The other thing we've been tasked to do, and one is the infection control training, but the other is to work with the county multi-sectoral response teams. That's the manual we have. We have a framework for that, and really a step-by-step way of doing things. So we're going to go out and visit those. Yes, I want to get out in the villages. But again, you know, you travel, no touch, you know, keeping a distance and things like that. I mean, there are hundreds, if not thousands of people who are doing contact tracing of known Ebola patients in the village without any coverage at all. I have bought long sleeve shirts. I bought a whole bunch of these LL Bean fishing shirts that you can sweat into. And so my arms are covered. Ordinarily in a country like Liberia, I'd be in short sleeve shirts, but I'm gonna, so I mean, that's what I mean about being concerned enough to take appropriate precautions. So we'll come back, we're gonna meet with the donors. We have an initial $5 million budget, which our team in Liberia tells us, look upon it as seed money, that we need to get up to 25 or 30 or 40 to really make this work. And so we have to get all the funding together, and then we go back in with the response team. And we do what's called cascade training. So a day in our life would be a training of trainers on infection prevention from each of the counties and providing them the skills and how to do it. And it is very intensive because, you know, health workers have caught Ebola even with all the equipment on. But what we find is little things, like the sleeve separates from the glove, or, you know, people maybe get itchy and they go like this and, you know, bam. In fact, I think the nurse's aide in Spain who was infected admit that's what she did. She scratched her forehead. And so this training is very intensive, and you make sure that everybody is 100% on board, and then they go out and repeat it. So we may go with them, maybe to get it started. I've done that a lot. And that I may do the first day and then step back and let them take over and do all the training. So we've built the capacity of the country to carry on the training even when we're not there. So that's what our days will look like.
On a regular basis, as this grows exponentially, you're going to be in restaurants and in a hotel, and you're going to be in contact with people. How will you know that everybody is free from the virus?
Another good question. Of course, you know, whether it's Kabul, where I've lived, or Saigon, you know, how do you know the people eating next to you don't have a bomb strapped to them? I mean, it actually is easier to screen for fever. So we're staying in a hotel where they screen all the workers every day for fever. And if anyone has fever, they're sent home. In order to go into the hotel, you have to disinfect yourself, your hands. You have to walk over mats that have disinfectant in them, so you're not picking anything up on your shoes. And all the utensils and plates are all disinfected in chlorine water. So, you know, the particular hotel we're in declares themselves Ebola free, and I feel comfortable with that. Will I be traveling around Monrovia, going to restaurants? No. because I would never know what my server's doing. All of us, don't we? I mean, do you all just stop working when you get sick? You don't usually. You just go to work and tough it out. And I don't want to run into that in a restaurant when somebody's coming down to give me a plate and touches me. So we'll stay pretty close to home. But again, I'm used to that. I've been to Kabul twice this year, and I can tell you, the car drives into the guest house, you get into the car, it drives out, goes to the office, the gates open, they close, you're there. You go to the Ministry of Health, the gates open, you go out and go right into the ministry. There's not much life. In fact, my favorite restaurant in Kabul was exactly that Lebanese restaurant that was bombed and everybody in it was killed back in January. I mean, we knew the guy, but you know, you just don't go out. You know, that's what I mean about being careful.
What are the symptoms? I know that might be a dumb question to you guys, but you know, it sounds like the symptoms of Ebola are the symptoms to the flu.
They are. Exactly that, in the early stages.
Exactly what?
Like the flu. You'll get a low-grade fever, you feel punky, a headache, you may get some nausea, but it progresses very rapidly once you get the symptoms, you know. I mean, this poor Liberian fellow in Dallas, from onset of illness to death was what, 7 days or something? I mean, and I knew he was going to die because on day 5 he was on a ventilator and dialysis. And,
It progresses very quickly to what? Break down your immune system?
yes, it's multi-system failure. Total multi-system failure. Interestingly enough, the hemorrhagic symptoms, the fancy name, if you want to write it down, is disseminated intravascular coagulation, or DIC. The virus attacks the ability of the blood to clot, is what it amounts to.
And you were saying earlier, you guys kind of chuckled, and when we asked, why aren't the systems in Boston equipped that we're sending people to Nebraska or Atlanta? Why aren't the hospitals here equipped to deal with something and treat someone with Ebola?
Oh, they are equipped.
Then why aren't we treating them here? Why are we sending them to Nebraska or Atlanta?
Well, that was just, I think, probably an organizational choice. So I think there have not been cases that have been seeking care in our area, but I think the Boston hospitals are well equipped to manage this.
If I may say, you interrupted me.
Okay.
The hemorrhagic symptoms are a minority of cases. Only 40–45% of cases get the hemorrhage. So all the rest, it's all fever and just crash and shock and everything else. But the hospitals are equipped to deal with that.
And just a couple points on the evacuation. And we've had several conversations. This is top of mind for the person, Dr. Navarro, who's running the Ebola response for the UN, is care of health workers. And the evacuation planes, special planes, pods, staffing, and all that, very limited supply. That's a real issue. So part of the question is just the logistics of what choices you have given the evacuation capacity. The other thing, just to come back on one really key theme, we've been, I think, reasonably focusing on the health of the guy next to me, but all of the kinds of things he's facing, the people in Liberia are facing by the millions. And so the question is, where do they get the sort of supplies, the sort of protection equipment, all of that? And that's where a key part of this effort of ours is to take advantage of the MSH accredited medicine shops that have been set up and the sort of private sector normal channels there to get these products out so that they're available to the people in the community, because that's a key part of stopping the epidemic. We've also talked about the importance of sort of crowdsourcing detection, so you know where there are outbreaks and can get there.
Clearly this work that you guys are doing is amazing, and you know, thank you for inviting us here today, but what makes you so confident you can really go over and help out? I mean, this is an insane illness that's just ravaging this country right now, and it's scaring everyone worldwide. What makes you guys so confident that you can really go over and help out?
Because you've got the leadership in Liberia at each of the levels is coming together. Each of the levels is coming together. There are partners in the Ministry of Health at each level. And there is a much more organized international community with each different part of it playing its role, with the Center for Disease Control, with USAID, with the OFTA, with UNICEF, and people are saying it's got to happen. And so the local knowledge commitment and at each level connectedness with the international know-how, we've seen that come together before. The epidemic, the response was slow for a variety of reasons, but it is coming together. And as Dr. Hartman has said, we've seen it to the end. The question is how quickly, with other epidemics, and the question is how quickly these efforts will come together and have an impact.